And Dr. I can take it away. Thank you.
Wonderful. Well, thank you everyone for being here this morning and joining our discussion. Today, we're going to talk about strategies to effectively conduct outreach in sickle cell disease. And I'm going to discuss a lot of those principles that we want to use or think about using as we implement our programs to conduct outreach to individuals that have sickle cell disease, drawing on the importance of really understanding and considering the community's needs as you start building your program. Now, I want to start with some excellent news. When I was born back in the 1970s, I was born in 1971, the life expectancy for an individual with sickle cell disease was about 8 to 10 years. And so there wasn't a lot of hope for individuals that had the disease to live into adulthood and have a productive life. However, due to research findings, due to information we gathered around sickle cell disease, we're able now to effectively treat sickle cell disease, and individuals with sickle cell disease can live well into their 50s. You'll see later today that the average life expectancy for an individual with sickle cell disease in Ontario is actually 55 years. But it was through those advancements, including looking at penicillin prophylaxis, the importance of newborn screening and hydroxyurea, as well as other therapies, that we're able to now provide individuals with sickle cell disease the treatment that they need to live a long and full life. Me personally, I'm an individual living with sickle cell disease hemoglobin SS that's currently 54 years old. So I look to living a lot longer. But as we look at how we help our community members to live that long, productive life, we have to consider the barriers that they may have in their community. And in 2008, the National Heart, Lung, and Blood Institute conducted a study. They looked at, well, what are those barriers to hydroxyurea utilization? Hydroxyurea had been approved by the FDA as a therapy in 1998. But 10 years later, in 2008, only 10% of individuals with sickle cell disease that could benefit from hydroxyurea were actually using it. And so they looked at what are those barriers, and of course, a lack of knowledge about hydroxyurea as a therapeutic option. Yes, it's a new drug. Communities didn't probably know about it, but there was also provider level barriers as well. There was difficulty in communication between patients and their caregivers. There was a lack of adherence to treatment regimen, but there were also provider biases and negative attitudes towards individuals with sickle cell disease that presented a barrier. There was a limited number of providers, physicians who had the expertise on using hydroxyurea. And then there was a failure, most importantly, a failure to engage patients and caregivers in the treatment decision process. We have to consider that, hey, hydroxyurea is a wonderful drug. We have these other therapies, but not every sickle cell patient may feel that that's the right therapy for them for a number of reasons. And we have to figure out strategies that really engage the patients, meet them where they are, and help them in that decision-making process. So now taking a look at sickle cell disease in Ontario, Canada. So there was a study that was conducted by Ontario Health, and this was back between the years of 2007 and 2017. They used administrative data to really look at the sickle cell community, and they determined that in Ontario, there were about 3,400 individuals, unique patients with sickle cell disease. The slim majority of them, 55, maybe 56%, were female, and the median age of the sickle cell population in Ontario that they determined through this study was 24 years. Now, in that 10 years that they conducted the study, 229 patients did die from sickle cell disease, but the average age at death was 55 years. So that's great news. We now know that our patients are not only reaching adulthood, but they're living well into their 50s. And then the estimated prevalence of sickle cell disease in Ontario was 1 in 4,200 individuals. And you can get this information on the website that's established. But we know that recently there's been a lot of immigration into Canada, a lot of immigration into the United States. And if we take a look at where sickle cell is prevalent and line that up with where the immigration is coming from, we can see that we're getting quite a bit of immigration from Africa, sub-Saharan Africa and India. And those two areas have a huge sickle cell population as well. So as we consider building our programs that are going to do outreach to the sickle cell community, we have to take into account that immigration may have changed that demographics of individuals that we're targeting. We have to now consider that, hey, there could be a large, for example, Indian population with sickle cell disease that we're missing because of certain ideas or stigmas or thoughts that we have about sickle cell disease. So it's important to consider cultural competency, language-related barriers, and other factors as we continue to build our programs. So why is community outreach important anyway? I mean, shouldn't we be able to, hey, the hospital's there. If people are sick, they know to go to the hospital. You know, why do we need community outreach? Well, community outreach really enables organizations to engage with their local communities, learn about that community's needs. What the hospital may assume or think is the community's needs may not actually be what the community feels are their needs. So there needs to be some understanding, some meeting of the minds between the healthcare system that is really there to serve individuals and the communities where individuals live and what they feel their needs are. So we need to figure out ways to collaborate together and address those needs of the community members. As we begin to think about our outreach principles, we want to make sure that we're clearly identifying the people that we're trying to serve. This can include, hey, there are patients in this location. So, hey, do I want to do all of Ontario, or am I going to do a specific part of Ontario? Is my effort going to be based in London, or is it going to be in Toronto? You know, and then even there, you have to think about what subpopulations do I need to consider? Am I reaching out to the immigrant population that's recently from African nations? Am I reaching out to African Canadians that have been in the country for a long time? Because each of those scenarios may have an impact on how I tailor my outreach efforts. We then want to tailor our outreach strategies, our messages, and our materials according to that target audience that we have identified. We want to make sure that, hey, we understand who the population is. We understand the resources that they have, so that as we engage them and we talk about them, we're able to tailor our messages and our materials to suit their needs. We want to think about our client and community's perspective. You know, when I was working previously, we would work on strategies and try to improve access to healthy foods. And it's not appropriate to go into certain communities and say, hey, you need to make sure you're buying fresh fruits and vegetables, when that community may be in what's called a food desert. And it may be extremely difficult for them to get access to healthy foods. So we want to make sure that we're considering that client's perspective, what we're asking them to do. What are those challenges that might exist in the community that might be there to prevent them from doing, from achieving the messages that we're trying to do? We want to include information about the services that we want to give to the community. We want to help the community to understand who we are and why we want to be there to help them. What is our role in helping to provide them services? So SCAGO is a community-based organization. It doesn't provide what I would consider direct sickle cell care. We don't actually prescribe hydroxyurea or treat sickle cell disease, but we're there to serve as that community-based organization to link individuals to those services. And so explaining to the community our role in the process, how we relate to different stakeholders is very important. And then we want to enlist key leaders in our approach. We want to make sure that before we go into a community, we not only understand the community, but we understand who are those leaders in the community that can get movement to happen. You know, that might be, hey, we're identifying a church that is a leader in the community. We're identifying another community-based organization that the community really respects. And we're making sure that we're reaching out and engaging those individuals as well, in some cases to be ambassadors. So other principles that we have to think about is outreach equals material plus personal contact. It's not just enough to put your materials on a desk and say, hey, I've done community outreach. You also have to have that personal contact occur where individuals in the community are getting to know who you are. You're there physically interacting with them, and you're doing that in multiple ways and at multiple times so that the community begins to build that trust. The trust comes from seeing a familiar face. And so if you're just around at Christmas time, or you're just around at certain intervals, and you're usually not embedded in the community, then there might be that situation where you have that difficulty then in gaining that community trust. You want to be a conversationalist and not a preacher. I have to admit my own flaw. I'm a huge advocate for hydroxyurea. I want everybody with sickle cell disease to be on hydroxyurea. But as I approach the community, I have to understand that the community members have certain needs, they have certain wants, and that's different from me. So I don't want to go in and preach the gospel of hydroxyurea. Instead, I want to be a conversationalist, listen, and help to understand, hey, well, what is their viewpoint? So it's important that we don't go in and we become preachers, we don't become gospels of sickle cell disease, but that we listen to and engage the community in the proper way. We also want to create a system and scheduling for providing outreach. And I would say that this is office hours, right? You want to be, hey, make yourself known that we are here to help you, and this is how you outreach. This is how you reach us. This is where we are. Come and visit us. So you want to provide those office hours. Now, I know that a lot of assistance now can be given over the internet and virtually. So there are some services that are available virtually, but you still want to make the community aware of when you're able to be reached, of when you have that virtual office hour. So whether it's a building where you're providing services, or whether it's online, you still want to make the community aware of how they can reach you. And then you want to also take advantage of where we've come. We now have social media, we have social networks, Facebook, TikTok. All of these are resources to help us reach and engage our community. I know here in Ontario, SCAGO is a big user of WhatsApp. So we want to look at how do we use those new technologies such as WhatsApp to really engage our community members and make them feel a part of the effort that we're trying to conduct. And then we want to consider where we have done outreach and think about who's missing. As I look around here in Ontario, Ontario, just south of Toronto, I know that the immigration population has brought in a lot of individuals from foreign countries, including Africa and India. But I often think, well, hey, we know now that sickle cell is very predominant in the Indian population, but we may not see them as often at our events. So we want to think about how do we outreach to those communities that may have a high prevalence in sickle cell disease, but that we're missing for some reason. And another example would be, efforts made in California. So we're just gearing our efforts to the traditional African-American community. Are we missing the Latino community that might have sickle cell in our communities? So as we plan our process, we want to make sure that we're thinking about the outreach lifestyle. As I said earlier, outreach is just not about, hey, I print some materials, I go out into the community and I hand them out. If we do that, then we never understand where we are. We never understand how effective our community outreach has been. And we make certain mistakes as we move forward because we haven't developed the process in that outreach lifestyle that really allows us to determine where we are and where we want to go. So that outreach lifestyle includes planning. So we need to think about that needs assessment. What are the needs of the community? What are some of those barriers that exist? If we're doing a health food outreach effort, we need to know, hey, are we in a food desert? And if we're in a food desert, what are those resources such as farmers markets or community gardens that allow me to overcome those obstacles as I deliver my message? We need to think about our goals and objectives. Hey, we're a community-based organization. We're not providing direct care. So for me to say, hey, I want to increase the level of hydroxyurea utilization, well, I have to have partners that prescribe hydroxyurea that allow me to do that. But my goal and objective might just be increasing awareness about it. right? I'm not increasing utilization, I'm increasing awareness, but that's my role. I have to understand then what is my goal and objective in the process. We need to understand that stakeholder identification. Who are we serving? Where are we serving them? You know, are there language barriers? Are there cultural considerations that we need to have? And then we need to think about what our key messages is. We often get our message muddled because we have too many messages. We want to achieve too many goals at once. So we need to step back, really think about what are those key messages that we want to deliver and make sure that they're part of our planning process. We then want to look at develop. How are we going to structure our implementation process? Who's going to be where? Who's that team member that's engaging with the community? How are they doing it? Where are they doing it? What resources are they giving out? So really thinking about that structure of implementation, the who, what, when, where, and why of our process. And then look at our outreach tools and mechanism. Are we doing online outreach only and making sure that we're looking at that? Hey, what is that structure? How are we using it? Or are we doing in-person outreach? So making sure that we're looking at the tools and materials, the mechanism that we have for outreach. Once we've considered all of that, we've identified our population, we know what our key messages are, we know that we're going to do outreach this way, then it's time for execution. So we implement the program by going out and saying, okay, on this day, I'm going to do this outreach activity with this population. And then I want to be able to look at, you know, how effective that was. So then you have that execution strategy. And even during that execution strategy, you might need to make adjustments to your program. You might see that, oh, I'm just not executing it properly in this avenue, so let me make adjustments. And then very importantly, what a lot of community-based organizations may not do as effectively is looking at that evaluation. Did what I do, did the goal and objective I have, was it met? You know, was I able to accomplish what I wanted to do? And so we want to look at that evaluation process. We want to look at the outcome. That's very important. Did I reach 50 individuals? Did I reach 500 individuals? But we also want to look at the process. How did I do it? And can I have done it better? Is there another way that could have gotten me a better results in that process? Another part of evaluation, though, is that you want to keep in mind the sharing of that as well. Because, hey, you know, did you do a wonderful job? And so how can you use your lessons learned to help others that may want to also do a program as well? And we want to make sure we're looking at those results, you know, analyzing how well it did. How many people did I reach? Were they satisfied with what I did? Can they give me feedback on how to do it better? So making sure that we're considering evaluation in our process. Now, as we start to serve our communities, we want to make sure that we're keeping an eye also on the social determinants of health. And the social determinants of health are those conditions in which people born, they grow, they live, they work, and they age. So that's their housing, that's their access to foods, that's their access to transportation. You know, are there barriers in their social determinants of health where they live that may be a constraint? And it starts at the individual level, but it doesn't stay there. It starts at how old the individual is. If I'm targeting a 12-year-old or a 15-year-old, that's going to be a different initiative than if I'm targeting a 50-year-old or a 60-year-old. So age is a factor, you know, their mobility is a factor, but then it's also the things around them. You know, their access to transportation, as I said. Do they have grocery stores in their neighborhood, or is it occupied mainly by convenience stores and dollar stores? You know, do they have walking trails, or do they have areas where they can exercise, or is it a lot of highways around where they live? So we really want to think about those factors. The social determinants of health can dramatically impact a health indicator and outcomes related, and I have cardiovascular disease here, but other diseases as well. You know, if I'm prescribing hydroxyurea, do they have access to the doctors that prescribe the hydroxyurea? How easy is it to get to the pharmacy? Do they have insurance coverage? All these things have to be considered. And if they're not considered, they can really complicate your efforts. Coordinating community-based interventions are needed to help make those long-term, those larger scale impacts in health behavior. So, we can do a huge health behavior, but if we're not considering those social determinants of health, then our programs can be ruined because we didn't consider factors that are around the individual that can be a burden. And then we want to reduce health disparities and improve health outcomes. That requires participation from key public as well as private institutions. What are those community health centers that are in the neighborhood to engage patients? What are some of the messages that they're saying? And do our messages align? We have to figure out how to really work with partners to make sure that we're addressing the healthcare needs of the individuals in the community. And as we implement our program, we have to consider that there are what I would consider institutional barriers. When I say institutional barriers, I mean that, all of us didn't just show up yesterday, right? We come from a long history of individuals, and those long history of individuals have certain political and other things that have happened. There have been policies that have been implemented that have created some of these barriers that we're seeing today. And so we have to think about everyone may not be at the same place. And because everyone may not be at the same place, their needs may be different. And so we can't say, hey, I'm going to give one community the exact same thing that I give another community, because equality may not be our goal. We may not want to say, hey, we're going to give everybody the same thing, because that may not account for some of those past events that have happened that have created barriers. So instead, we want to look at equity. And equity means fairness. Equity is about making sure individuals get the access they need for the same opportunities. So we're not looking at, hey, are we giving everybody the same thing? We're looking at, are we giving people what they need so that they may achieve the goals that they have? And a part of that, I know it's the elephant in the room, is, of course, racial discrimination. We know that it happens. It's been well documented. This is one study that was done, I believe it was in Boston, on the discrimination of the healthcare system and how older Americans feel affected. And you can see that Latino and Black population in this study, over 20% of them felt the discrimination. They could feel that, hey, I'm not being treated fairly, whereas only 3% of the white population felt that way. And in this case, we need to make sure that we're thinking about racism and racial discrimination as we consider our program. There's a book I really love. I read it a long time ago, and it's about race and sickle cell disease, and how, if you look at how some structures came to be, of course, they're going to create barriers because they took into account those racial factors. So there's a history of bias and racism, and that's a barrier that we need to address. The perception of sickle cell patients as drug seekers, that can be very harmful to our efforts. And so we want to make sure that we're addressing that communication between the provider and the patient community as we build our programs, so that we can best suit the programs. And another model that I love to think about is the chronic care model. The chronic care model says that in order to get improved outcomes, we have to make sure we have informed, activated patients. Those patients have to be knowledgeable about themselves. They have to be activated to take a role in their health. But there also has to be that prepared, proactive practice team that's going to meet the patient where they are, that's going to work with the patient to achieve good outcomes. And then when you get a very productive interaction where that patient is part of the disease, decision-making process, and they're working with a knowledgeable team that's there to work with them and make sure that they're getting care, that's when we get our best outcomes. But we also have to make sure that we're looking at the system that they're in, those influences that can occur in that interaction with the patient and the provider. That includes the healthcare system as well as in the community. And so what we need to do is look at a multi-clinical approach. We can't just say, hey, we're going to improve patient health by looking at the institution. We have to look at the environment. What are those policies, such as JCO? JCO's in the US, such as insurance reimbursement, such as the national guidelines. but we also have to look at the institutional, clinical institutions, what they're doing, what policies do they have in place? Do they have electronic health records? Do they have patient monitoring systems? And the clinicians themselves, what are they doing? Where's their knowledge? How is their referral patterns? Do they have access to a specialist if they're primary care doctors? But we also have to consider the patients. What's their level of knowledge? What's their attitudes? What's their behaviors? And that's how we get improved health outcomes. So right now I'm gonna stop and I'm gonna turn it over to one of our outreach staff here at SCAGO, Temple. Thank you so much for giving this part. I can advance your slides also if you say next slides.
Okay, thank you, Dr. Ivy. I was actually getting at the venue now, so I'm trying to settle down. Good morning, everyone.
Do you want to present your own slides or do you want me to advance them?
No, you can go ahead. It's fine. It's okay. It's fine, yeah. Yeah, so basically we're in the field, just like we are in another program just right now. I hear the noise in the background. I had to get here before time. If I had to finish this one, it'd be difficult for us to get here on time because it has to start at 10. So this is what we do basically. We are in the field engaging with other communities. This is one of our strategies we use, engaging with other communities that are also doing in the health sector, especially with the Black. Little we have known is that there's more acceptance with the Black organizations on the Black community. They understand sickle cell more. Over time, we've tried to penetrate some of the other communities like the whites, organizations and stuff. Sometimes even understanding what they're saying, it's difficult to understand what they're talking about sickle cell. So it makes the reception and audience very difficult to get from them. So our strength has been on other communities that were Black, but African countries like Indians that are doing programs in the health sector. We engage them, reach out to them, take opportunity of the platform, and then speak about sickle cell, speak about SCAGO, about what we provide. Many people in the system, just like Dr. Ivy said, new immigrants have no idea of what is available. They have no idea of the healthcare, how it works. They have no idea of the support. The system, even when they go by themselves, the system does not. One was given a story when he went to the hospital. There was no audience. Let's say, well, they didn't understand what he was going through. And sometimes we get to the schools, you find out some kids have sickle cell, but even the teachers have no idea of what is going on with them. They just feel it's normal pain. So these are some of the things we do. When we get in there, we try to find out what's the population of students or people that have sickle cell there. If we find some of them, we have to refer them to our social workers, get them the rest information, provide them with the details they need so that they can actually be well guided. This is predominant with the Black. Most of the white schools we've gone into, sometimes we find it difficult to penetrate the front desk. These are some of the challenges. I'm just trying to go through the slides because where I'm not able to go into the slides, I'm in an event. So I'm just trying to give a summary of everything, we've been doing. Sometimes you get into this front desk, you're talking to them about sickle cell, they don't even know what they're saying. And because they don't know what they're saying, they're not interested. You want to leave the materials, you want to ask them opportunity to speak to maybe whoever is in charge. They will tell you, okay, just don't leave the materials. We'll look at it. I'll talk to the senior. If there's any room, we'll let you know, get back to you. Sometimes you don't get the get back, you don't get the feedback. But in most cases, if you mistakenly find a teacher or a parent there, you find that the communication changes. The interaction becomes very, very cordial. You will now see that research, you see that acceptance, you see that support. Go like, okay, so how and what you people do? They're able to now pass information. Most times, this is what we experience more in schools. Then in churches, it's been good anyway, especially with the Black churches too. They haven't done understanding, but most times the challenge is creating time, making out the time. It looks like there are a lot of programs here, and there's sometimes some of the organizations plan their program for the whole year. That is why even we've started planning with some small churches into next year already. We have programs that are already lined up, trying to finalize for next year. If you don't get these things, if you don't plan these things on time, by the time you're coming, they don't have no space for you. They have no space to put whatever you want. Even to have a meeting to discuss your program, they don't have that space. So what we do is have to try to reach out to them on time so that they can put us in their program. Then we have those interactions. Then with the school system also, one of the challenges we had was the education board, which I believe Sickle in the past had that connection with the school board. But when we come on board, we needed to reactivate that relationship to make sure that the school board, the access to the schools is very easy and very fast. Like most of the schools who want to restrict or stop us from coming in, we don't have the opportunity if we are coming from the school board. So that's one thing one of the school owners told us. Said, if we're coming from the school board, nobody can say no. We'll just be able to drop everything. We can plan a program ahead, even prior to whatever the school might think or saying, in the past. So it's been good. And within the few months we've been here, this platform has helped us to deliver a lot of materials, and information has gone out, creating a lot of awareness. And one of the most effective ways I can say, apart from this one, is what we are doing right now here in this event. Sometimes when we get to the events like this, there are other communities that might not have no Sickle, but they've not had access. They don't even know how to reach out to us. Sometimes they come to the desk, come to the booth and start asking questions. They will not go like, oh, okay. So I've been hearing about Sickle. What do people do? That is a good time to give detailed information. So it's not just about reaching out to the community here. Sometimes we're able to collaborate and reach out to other organizations that have their booths here. So sometimes we meet on programs like this. We met this African community in another program. We met other ones so when we went to the roots, the Black community somewhere in Brampton, we met about 5 different organizations, and they became very productive, right? We were able to collaborate with most of them, and then we were able to expand and reach out to more people. So I believe next year, with what we've done this year, putting these things together, we're going to have a lot of opportunities to do more, in the coming years. And I think these are part of these are our partners here. We've had events with most of these organizations. One bit with Rexdale, Black Creek. We just had our Christmas party was with Black Creek last Saturday, and it was amazing. Black Creek was very supportive. And in February, we're having another one with the Canadian Blood Service. So it's been a very, very positive year for us. I'm looking forward to next year. I know that we're going to do much more better right here. Dr. Ivy, thank you. I think.
Yes, and I just wanted to go back to emphasize then some of what Temple has said and some of the notable challenges that we're going to encounter as we begin to work in the field. So one would be, hey, non-Black communities, they may not have heard about sickle cell as much. They may not see it as a factor. But as I mentioned earlier, we do know that sickle cell disease is prevalent in the Middle Eastern, Mediterranean communities, in the Indian communities. So making sure that we're looking at them and that community as well to address their needs. And in the United States, as I said, there's been a lot of immigration from South America, and we know that there may be high prevalence of sickle cell disease in that population as well. And there may be, though, limited awareness about the disease itself. There may also be misconceptions about genetic diseases. So we might need to make sure that, hey, we're looking at this and we're considering that what is their knowledge about genetic disorders, what's their understanding of it. This can also be in Black communities where sickle cell disease was prevalent, and the viewpoint may have been different than our viewpoint here in the West. We want to make sure that we're providing that education, that we have the resources now to treat sickle cell disease. You may have individuals that are coming to Canada and the US from low or middle resource countries, and there was a level of hopelessness with sickle cell disease. These individuals are going to die before they reach 5 years anyway. That's what I saw in their community. Well, we need to engage those communities, say, hey, we have treatments now that can really help them live well into their 50s. And so helping those communities to understand that and making sure that there's we don't have that perceived irrelevance that, oh, if it's not a Black community, if it's not a Black disease, I don't need to worry about it because I'm not Black. So making it relevant to the populations that we serve. And in our outreach efforts, as Temple had said, we also have to consider some of those other barriers that may exist. We talked about the school boards and the schools, hey, our goal is to educate students, right? We don't have time for these extracurricular type activity. Or there might be another organization, as Temple mentioned, the churches. And this has been my experience as well. Churches plan out their whole year calendars in advance. So if you go to a church and you want to do an activity next month or next week, well, they may say, hey, we're sorry, we've already planned our activities for the whole year. So if you're going to engage those churches, if you're going to engage those other institutions, you want to make sure that you're doing it in a timely manner that allows them to be responsive to your needs and allows them that time to allow you to be there. We want to think about those stereotypes and those biases, those preconceived notions about sickle cell disease as a Black issue, or even about the patients that the patients are non-compliant and they don't want to be cared for anyway. We want to make sure that we're making sure we're educating individuals to counter those misconceptions. And then also those misconceptions about genetics. There's a lot that's going on right now in sickle cell disease. We have a lot of great care, so we want to make sure we're providing that education about the resources I have. And what I wanted to do, though, so the key takeaway here is that in order to build a really good, strong community outreach program, we have to recognize that it's a journey. It's a journey that requires dedication, strategic planning, and a heart for genuine engagement. Now, I've been doing community outreach activities with partners. When I was in the federal government in the US, I engaged in community outreach activities. And I know that it takes a lot of effort. A lot of times you'll start your program and it won't work out as you were hoping it will. And that can become very discouraging. But we have to recognize that we're not going to solve the problems of our communities overnight. A lot of these problems are historical. They're deeply ingrained in the community. So we have to figure out how do we create that long-term strategic plan and really have that heart to stick with it, to stay engaged even when we're coming up against barriers. We want to remember our ability to connect with our community on an emotional level, because that's what we really want to get to, is connecting to our community on that emotional level. That's going to be the cornerstone of our success. If we're not meeting them where they are, if we're not engaging them and allowing them to really lean on us as a partner, our program may not achieve the success we want. So we want to make sure that we're really engaging our community on an emotional level. And then we also want to make sure that we have goals that are clear, strategies that are acceptable, and we're going into this with ears open to the voices of the community. We're not going there to dictate to the community that this is what you need and we're here to give it to you. No, you want to go in and say, what do you need and how can we work together to fulfill your needs? And so I'm going to stop there. I wanted to leave a lot of time for us to have dialogue because, I wanted to hear from the audience and your experiences. Now, this is being put on by SCAGO, which is the Sickle Cell Awareness Group of Ontario. On here is the contact information for us, our website, our email, and then you can also join our Learning for Life events and programs. And then we are also on Facebook and Twitter. But I wanted to stop now just to have a discussion. So does anyone want to have, and I see that we have quite a bit of attendance and we do have some information in the chat. Just going to go through real quickly. But does anyone have any questions or does anyone want to make any comments about their community outreach efforts? I know each of us serve a different community. Yes, Carolyn, it's so great to see you. Can you introduce yourself and then tell where you're from and then your question?
Yes, good morning, everyone. Dr. Carolyn Rowley, Executive Director at Cayenne Wellness Center. I'm in California. We have a statewide program, and we, in addition to providing education, we have support groups, about 6 or 7 throughout the region. We have what's called STAC, which is our Sickle Cell Trait Awareness Campaign for the next 5 years. And that is to spread education on sickle cell disease and trait to the students, middle school, high school, and college. And my question is about just that. First year was we received a spreadsheet. It had about 60,000 schools. We also have the school district. So we began sending emails. Year two, which is this year, we uh, started promoting Stack via billboards regionally. Now we're going into year three. So we still want to get into the schools, but not just the schools, also the churches, because a lot of large churches have youth ministries. But my question is for the school, it's been challenging here um, in terms of I'm so open to whatever anyone may have because outside of knowing someone who goes to that school and asking their principal, we have already connected with the school district. Everyone already knows. They receive emails on a monthly basis, but we are having challenges with reaching our goal. And our goal has been at least 2 to 3 talks in different schools per month. Unfortunately, we've only had 4 discussions for the year. So we have not met our goal. And now we're heading into 2025. So I would love to be able to take back some suggestions to the team for them to um, go back to the drawing board and let's figure out how we can meet those targets for 2025. So that is where we are, and I'm so open to thoughts and suggestions.
Yeah, and thank you so much for that, Carolyn. I know someone had said in the chat that getting connected to the school board, and you actually mentioned in your talk that getting connected with the school boards, you've done that, and it's still been a challenge. Does anyone have any suggestions for school? I would say now, you had to take what I say with a grain of salt. But because I haven't actually engaged with the school board, one of the things I think you can do is like if you identify schools that have patients and then kind of use them as an endpoint to say, hey, you have a sickle cell patient that has a need here. Are you able to address that sickle cell patient's needs? And what are you doing? So if you can identify maybe a few sickle cell patients within that school board and then talk to their parents and say, hey, we want to work with you to create a situation, and then have that parent go with you and they be a lead. Because usually, like even in politics, people are going to listen to their constituents.
Yes.
And they may look at you as, hey, you're an outsider, you're not a constituent. But if they have that student and that parent there and they are constituents, that may lend more weight to your voice.
I appreciate that. So I'm going to just repeat. I think our next step is sending out something to the community saying, hey, we would love to come to your school. We don't have to identify you, but we would love to come to your school and let us know if you want to work with us so that we can.
Yeah.
Yeah, I'm going to figure that out. I appreciate that for your moving forward. Thank you.
Okay. Grace? Grace, you're on mute if you're talking. I know you have your hand up. Okay, I think there were comments that came in the chat. Someone said that a meeting with the superintendent should end with scheduled meetings with principals. Meetings with principals should be with the end goal of assemblies and literature being sent home. You also have parent councils may be a good entry point as they are most invested in their students' health. Okay. Does anyone else have any questions? Yeah. Yes.
This is Shane from Roots Community Services. One of the things that I can say that we have we have tried and seem to have given us some results are when we have students who are, who have asthmatic condition or having EpiPen. I don't want to compare the two in terms of persons, living with sickle cell and so, but what we have done is that we have met with the superintendents around the safe schools and look at how we can begin to, from the equity inclusion lens. And right now we do have a program around building safer communities. And I can tell you, once you get that superintendent on board, you can move mountains because you send to the principal, it comes like another communique. You send to the parent teachers body, they have to begin to, but once you can begin, and I would suggest have, and for the Peel School District School Board, we already have an entry point, and so I can share that with the folks around who we have been in contact with, get the superintendent to sort of buy into the pieces, understanding the importance, and from there we can navigate this sort of entry that is needed into that space. And so I'm happy to share those pieces with folks, and we have seen how the process not only have been accelerated, but the efficacy in that role, because when you're a principal or even a CEO, the bombardment of emails and how do you prioritize and how do you begin? And that safe school component, I'm speaking about Peel, have proven in some ways to work. And I know the contact for that superintendent. We are planning on doing the Building Safer School Safer School program there. So we can sort of intercept that and create an alignment and say, look, we have these students, how can we do the referral? And I think what we can do as well too is that because we're in a unique position in Peel and we do have the Black Health and Social Services Hub, we can create some kind of bilateral relationships that is synonymous to all the partners, and I think we can move forward. So I'm happy to have sort of dialogue and discussion with those that are looking to sort of navigate those pieces.
Wonderful. Thank you so much for that information. Grace, I see that you had you're back on your hand up.
Yeah,
Yeah.
sorry, my mic wasn't working. I wanted to add, I think Carolyn suggested that she was going to go into the churches. I think it also might be good to highlight that when it comes to homework and handing things on time, although, sickle cell is not a physical disability that you can see, I found getting the community involved by letting them know they can have accommodated time, whether if they want to hand in stuff like maybe a week later because they're not feeling well. That might be another drive to get churches and community members more involved to convince the schools to make this a precedented thing.
Wonderful. And there was someone that mentioned in the chat about using parent organizations, parent teacher organizations, and that could be a strategy that's employed. So we want to look at how we really engage those schools because that's important. We mentioned earlier that individuals are living a longer, healthier life. We want to make sure that our sickle cell patients then are able to use school the way it's needed so that they can become productive members of adult. And if we're ignoring school and, hey, we're only treating their sickle cell pain when they come to the hospital or when they're at the emergency room, then we have a huge gap because then we have a population of sickle cell patients that, yes, they're living longer, but they're not achieving those educational goals, those work goals that we may have. So we definitely know that school is an important part of our efforts. Does anyone else want to make a comment about their outreach efforts? Okay, we're going to go ahead just because I know we're getting close to time to do our poll. And because as I mentioned, you always, with all of your outreach efforts, you want to consider your data collection strategy. How are you going to account for if you're doing a good job? So there is a poll, but please still, if you have any questions or comments you want to make regarding our discussion today, please feel free to raise your hand and I can call on you. So I didn't want to do this, but I'm gonna just then call out some people then about their outreach experience. I see Dan, you're from Rexdale, since your camera is on. would you mind just giving like a brief introduction of who you are, and then any information on your outreach experience?
Serves me right for having my camera on. Yeah, I'm the seniors program coordinator for Rexdale Community Health Center seniors program. And a lot of the seniors we work with, we have a separate Somali program that we use for Somali citizens, seniors. And we also have a big Caribbean community as well that we try to target with our outreach. We try to address social isolation and food insecurity, as well as all the social determinants of health that you already addressed. And I'm just here to learn a little bit more about this issue. We both basically, my role is basically talking, dealing with recreational therapy and recreational, trying to engage seniors. Some of my other colleagues that are on here would deal more with the primary care, healthcare side of things, which may be more directly involved. But it's good to get the information and appreciate this training.
Wonderful, thank you. And Arlene, I see that your camera is on. Do you want to just talk about a little bit about your outreach experience and what have been some of the barriers you've encountered when working in the community?
Yeah. Well, I don't have very much outreach experience so far. Barriers, I wouldn't really highlight barriers so much so far. Mainly knowing who to get in contact with, I think, would be if I'm branching out in the area that I'm closest to, that would be. And we've gotten a lot of information today in this session, actually. So.
Yeah, and I would say, bringing up your point, like who to get in contact with, who are those leaders in the community that can pull that lever, and sometimes when we consider our communities, we have to think ahead of time about who do I get in touch with. If I'm going to do an outreach to a church, do I go to that pastor or do I go to that pastor's secretary, or who is it that has that in? And I've found with some of the work that we've done that, hey, sometimes that mover and shaker, it isn't the pastor of the church. Of course, they're making that big decisions, but they have another person because they're so busy that they rely on, and they're able to then working with those individuals to grease the wheel. So really, like you said, identifying who is it that we need to engage in order to really serve as the voice of the community. I'm going to call on then somebody I know to just give a comment. I see his name up here. I hope I'm not putting too far on the spot. But Jimmy Pinnock, if you're able, can you introduce yourself, and if you've done any community outreach, just give a little bit about it.
Yep. Hey, Doc, no problem. So yeah, my name is Jimmy Pinnock. I have hemoglobin SC disease. I would say I'm new to the community outreach space. The way I got involved is through the VCU Sickle Cell Clinic that I participate in Richmond, Virginia. I'm from Suffolk, Virginia. And when I started participating in that clinic, I joined their VCU support group for men, which became an outreach for me because I'm 60, or I'll be 65 years old next month on January 4th. And a lot of the participants are younger adults, and they kind of eyes wide open when they talk about my age. And I take hydroxyurea too. It has helped me a lot as far as slowing down the complications that I've gone through, and I wish more could take it. And so I try not to preach it, but I speak from how it has benefited me. And I have had one of the young men actually start that treatment. My other method of outreach is I recently started volunteering with the local CBOs here in Virginia, Sickle Cell Association of Norfolk, and there's another one in Virginia Beach. And through that, I was able to, and I utilized that as with a contact that I have with Head Start. And I made it aware to them that, hey, I have SC disease. I've recently started doing outreach. And I would love for one of our CBOs to come speak into your, into your program, because they run like several of them. And so I think that's going to be very positive next year, where they're going to work us into their schedule to come speak on it. So those have been my two avenues, along with, like I said, I was also invited, I'm sorry to be so long, but Dr. Wally Smith invited me to come speak at the NIH and HHS, which was a great opportunity. And actually, Dr. Ivy, I was contacted by two individuals that listened to that speech and presentation. And one of the individuals actually had a procedure done that I had spoke of at that. So that too was rewarding. Thank you very much.
Yeah. Yeah. And as you mentioned, particularly if you're a sickle cell patient. So I am a sickle cell patient. Mr. Panak just mentioned that he's a sickle cell patient. Sometimes using your personal experience can be another way to improve that. I'm getting that message across. You don't want to become preachy, as I mentioned earlier. You don't want to knock people over the head about it. But sometimes just talking about, hey, this is what I experienced, and this is what I did, and this is how it's worked for me. That can inform patients that they do have choices. Sometimes they just may not be aware of those choices. So I know we're at time. I do want to thank everyone for joining our discussion today. I'm just going to put my contact information back on the screen as we begin to head out. But yes, I wish that all of us, can work together to figure out how to improve the lives of individuals with sickle cell disease. So thank you for being here today. And I know I probably won't talk to you again. So have a wonderful, wonderful holiday season. Thank you, everyone.
It's the steady kind of